Well, welcome back to the class. We discussed chapter 1 and chapter 2, discussed some things about legal concept, risk management, and ethical issue. Now we will be transitioning on to the third chapter where we'll talk about the surgical patient. Once again, if I do tend to speak a little bit faster at some point, you may slow me down or ask questions, interrupt me, and I'll be able to repeat some of those things. I will try to speak as low as I can or as slow as I can so I can get some of these points across. We are doing good, happy to have good participation and moving forward. Hopefully, we can knock some of these quizzes and exam out. We do have two more chapters before you can definitely take your first exam. I hope you have been reading ahead, doing some of these chapter how you call it chapter tests that comes across. Every chapter happens to have a 50 to 75 questions. The only way you'll be successful in this class is to follow some of those recommendations I gave you as you read the chapter. Be able to answer the questions that came out with those chapters. Continue to do your discussions on Blackboard. Um, as you're doing the discussion, what I would encourage you to do is think out of the box. Don't focus on the answers that's in the textbook. Most of you are either um, you either been scrubbing for a while, so you can make some of those decisions from your personal experience while you do your discussion post. It does not have to be based directly on the textbook. Yes, I will encourage textbook answers, but I would like for you to think out of the box and encourage you to have that discussions among yourself. Uh, and once in a while, we'll chime in and give one or two pointers, and we can go from there. Some of the things that we'll be talking about today is chapter 3. Um, and then I will be posting some review materials online shortly to help you cement the information that we have already covered or that we have already reviewed. Some of those things that we'll be talking about today is to understand what do we mean by the surgical patient. But before we do that, let's go over our objective. Normally, objectives are given for a specific reason. Now, after studying this chapter, um, as I read these objectives, I will be throwing my own personal technique into it. You can all read these things on your own. PowerPoint slides will be available for you to take a look at. This is just for you to listen to on your time. After reading this chapter, our overall hope is you will be able to assess a patient's response to illness and hospitalization. While you're doing that, you should be able to demonstrate the awareness that all surgical patients have the right to high to the highest standards and practices in asepsis. Um, we should be able to distinguish and assess the physical, spiritual, and psychological needs of a patient. And that will be based off of the Maslow hierarchy of needs. Be able to distinguish and assess the cultural and religious influences on surgical patients, because again, every religious happens to have some type of impact on patient care. Compare and contrast the patient's responses to the process of death. Discuss the procedure for patient death in the operating room. Other people say patients normally don't die in the operating room. They either die on their way to or from the operating room. But again, we'll talk about some other things as we continue on. And now we continue on with the surgical technologies. As we look in chapter, as we look back to chapter 1, where we gave you a historical track record of where surgical technologies came from or how it became existent. Um, you will understand that most of these things happened back in during World War II from Great Britain, but this is not for me to take you back to that, but this is just to give you a quick review section. Because chapter one, we look at the surgical technology. We describe it as using the common definition of a professional, that is an individual who has some type of specialized education and training in a given field, and this individual normally meets certain competency based and ethical criteria. Their primary role is uh, to render care to a surgical patient while providing some type of assistance to the surgeon or the operating room staff during a surgical procedure or during the intraoperative phase. Um, I normally establish the protection of um, the sterile field during the procedure. The care provide care and handling of surgical instrumentations and provide assistance with technical tasks throughout the surgical procedure, whether it is the pre-operative, the intraoperative, nor the post-operative phase. The thing about surgical technologies is that when we normally refer to the tasks that they perform as those three different areas. These are the three things that we will talk about most of the time in this entire textbook. When we talk about surgical technologies, we're talking about the tasks that they perform in the pre-operative phase, intraoperative phase, and the post-operative phase. Because these individuals are typically tasked to perform within the operating room, right? That's where they normally do their job. That's what a surgical technologists normally do. In a quick overview, that's why you will see surgical technologists doing. They have a lot of different gifts that they can use, but their primary area of operation is in the operating room. Now, what we have these individuals in here, we can also understand that when we start looking at the physical, psychological, the social, and spiritual needs of the surgical patient, we can understand that for every surgical patient, the surgical intervention is physically, psychologically, socially, and spiritually, and it is a spiritual event. We imagine for a moment the question that will pass through the minds of I call it a young woman who is about to undergo, or a young man. Well, in this case, a young woman who is about to undergo a hysterectomy, right? Hysterectomy just talks about removal of the I call it it's a GYN procedure. So let's just say this person is performing what a male staff having hysterectomy done, and then we'll be asking a lot of questions. But let's focus on a female for a minute. For the male side, we can consider that to be maybe having a vasectomy or something like that, to be gender neutral. I just use female because of hysterectomy, but we can consider male and talk about vasectomy, not to offend anybody out there, but let's just consider that. But in this case, let me just continue. Okay, we have the male. Male is having a vasectomy done. What changes will this male person body go through? Who will this person um, who would this person be as a husband, right? If they have a vasectomy done, are they expected to have kids? Are they going to find someone that will be interested in having kids and they can? Because you can have vasectomy for a lot of different reasons. Either you don't want to have kids, or there's something else going on that you have to get those things done. But it could be for other personal reasons too as well. Now, when these things are happening, these are profound questions, right? That one can actually be asking themselves, because now they're having to deal with the physical part of their body, right? Will my body be the same? Because your body was fine at first, personally, but something happened and you have to make that drastic decision to have a vasectomy done. Uh, Other thing now, the next one is, since we already understand the physical part, we then transition on to the psychological part. Now, if I had a vasectomy done, who really am I? Right? Why did I do this? Everybody else wants to have kids, but why would I go have a vasectomy done? That's the other question now that they will be asking themselves. If for some reason the answer to those questions is not feasible, we can go on, because now we already focus on the physical part and the psychological part. Physical part is you did something physically to your body. Psychological part now is messing with your mind. Now the other thing now is, let's look at the social part. Who am I in my social role as a husband or as a father? Am I going to have any kids? Would I adopt kids? So you have all these thought process going through your head. And then we'll look at the spiritual part, and we'll look at, hey, what does this say about my belief as this religion? Is this something that's acceptable in my religion? Is this something that's different? It becomes the questions that we keep asking ourselves over and over. And then it takes us through a lot of different process, which we're going to talk about later on, the grieving process, the coping mechanism, all those things. It takes us through a lot of different things. But one of the things that we'll take a look at here first is to understand these different needs, right? In order to understand these different needs, we have to understand their definition. And we can use these by referring to the components that make up the needs of an individual. Now, for individuals normally have physical needs. These physical needs focus on any needs or activity that are related to either genetic, physiology, or anatomy, right? We have to meet those needs for some reason. If something will focus on genetics or physiology or anatomy, one of the things that we need to sustain ourselves physically is for our food, water, and drink, right? Food, food, water, and oxygen. Other things that you also see is the psychological needs. This focus on any activity that related to identifications and understanding of oneself. If you can't do any of those things to understand yourself psychologically, you other people say you're psyching yourself. And then you have the social need that goes on. If you cannot relate yourself, your identification, or your interaction with another individual or another group, then socially you're lacking some type of social skills. On the spiritual side, if for any reason that our identification and understanding of our place in this universe is being hard to comprehend, in other words, to say that we fall short of expression, or fall short to be involved in some type of theology or physiology or methodology, or even into intuition, it then becomes a problem for us. Now, none of these features exist alone. Okay, they function together in a dynamic state. This is where Maslow now came up with his hierarchy of needs. Now, the thing with Maslow hierarchy of needs is that it established a means of prioritizing these different needs effectively for the basic understanding of individuals, for individuals, and for quick recognitions of patients' concern. So all these different things we're thinking about, the physical part, the psychological part, the social and spiritual aspect of it, Maslow came around and said, okay, well, these are all things that everybody goes through. Let's do this. How about we take all of these things and put it in one category, one area, and then prioritize them in order. We have order 1, order 2, order 3, order 4, and then you go all the way up to the top, and then we'll go from there. So we decided to understand some of these things. But before we can understand some of these things, we have to look at, well, we can pay a little bit, we can stop a little bit and focus a little bit of light on a surgical patient as a human being, not a surgical patient as a patient. Now, the thing about surgical patients as a human being is that they are first and foremost people, right? Like us. They have an entire life outside the role of being a patient. That life is at a risk with every surgical intervention that they tends to have. The person who is the person who normally, well, who brought them into our operating room or your operating room is not the hysterectomy in that room or the vasectomy that's in that room, whatever operating room that they might be in. Because in your organization, in your hospital, you have specific rooms for specific specialties because of the equipment that are normally in those rooms. Now, since the person that brought them into your operating room is not the reason they came, or it's not the condition for which they are there, which of course could be they are not, it's not because it's not a vasectomy that brought them in there, because we're treating them as an entire person. We have to treat them as this individual with their name, or this single father with 10,000 kids, or this CEO of an organization. We have to consider them as that. Now, in the healthcare area, there is no place for someone who cannot or chooses not to care for a total individual. If you don't want to focus on this person as a patient, you don't want to focus on this person as a total human being, the healthcare area is not for you, because we have to pull all our differences, our bias, everything we have to throw out of the window and focus our attention on this person as a human being, as a person, as an entire person, not as a label of their condition. Now, if those things are happening, one must never lose sight of the total person. We should tend to do different things by ensuring that we don't violate our ethical and moral obligations that every healthcare professional has to every patient, regardless what their condition is, regardless the reason they came and whether they came and they were involved in a shooting somewhere and they started the shooting, whatever their condition is, whatever their story is, we should not be thinking of them as their circumstances, but thinking of them as their name, their title, whoever they are, thinking of them as a total person. Now, there will be some causes for surgical intervention. That's why they came in there. It could be something personal. It could be something that's not personal. But we have to make sure that we do not violate the ethical and moral obligations that we do have on our patient. Now, a surgical patient will have one thing in common. They are normally given all options. They will like not to have surgery. That's simple. They don't want to have surgery. Every surgical patient is very unique. They are all unique individual. All surgical patient has something that yeah, they don't want to have surgery. If they had the opportunity not to, they won't. Even when the surgical procedure is selected for cosmetic reason. It is selected because the patient is dissatisfied with his or her body as it is, or in, in sometimes having surgery because of genetic factors or trauma or disease, and have presented themselves in conditions that can only be or best be corrected with some type of surgical intervention. Now, let's also understand this. Surgery is often the last resort after other treatment and options have already been exhausted. Okay, we don't just jump straight into it. Now, other factors that could result into surgical intervention now would be some of these things right here. You have genetic malformation, right? If that's the case, some of those genetic malformation could be cleft lip, right? If that patient happens to have a cleft lip, you have to want to correct that before they grow up. It could be due to a traumatic factor. If that's the case, you'll probably see something like there's a tear, there anterior, there's a tear in the ligament somewhere. If that's the case, yeah, we're gonna have to do surgery. It could be some type of non-malignant neoplasm or some type of malignant neoplasm. In those cases, they have no other choice, whether it's a colon cancer or uterine fibroid or other things like that. They have no choice. Those factors, those are factors that will say some things like, hey, I know you don't want to have this surgery. However, these things have to be done to make sure that you are careful. But a surgical patient then is the individual who will become a patient because of some of these illnesses. They don't want to do it, but they have no choice. They become a surgical patient because of these factors that are being provided to them. It left with them. They don't want to know anything about this. They hope they were fine. They hope they don't have to go through uh, go under a surgical line. They hope that they will just stay in their environment and do the things that they're doing every day, all day. But that's not the case. It don't work that way because now they are a surgical patient because of some of these factors. Now, we look at the patient responses to illness and hospitalization. It's different. Now, we mentioned previously that every surgical patient is unique. They are all unique individuals, right? Now, in order for us to meet the needs unique to each patient, surgical technology should be aware of the sensitive to the patient's feeling. They should be sensitive to the patient's feelings and the illness and their upcoming surgery. Our behavior, human behavior in nature, in reaction to health, illness, and hospitalizations normally varies from one person to another person based on the age of the patient. But there are two broad factors, there are two things that normally apply to majority of the patient that patients that are normally adapted. They are adaptation and stress. Now, their adaptation to what they're going to and the stress level that they will go through changes everything. Even though we talk about this adaptation, and this is where we comes in with Sister Callista Roy, because she came out to break down these things into, she came to break these down into some type of coping mechanism on how people should manage some of these stress and how you call it, some of these stress that they go through. Now, her model came out when she brought her model out. She was very good at doing things. She said every patient happens to have their own problem. But when we view this patient as a psychosocial individual that is constantly interacting with the environment, with the ability to adapt by using coping skills in dealing with internal and external stressors, she came out and then interpreted the environment as all conditions, circumstances, and influences that normally surround and affect the development and behavior of that person. So two things will happen. Her understanding or an explanation is that the environment will either change the person or the person will change the environment based on their coping skills. If they're a heavy drinker because of stress, they will continue to be a heavy drinker and not heavy drinking. That will put more problem on their body or on their organ. It could turn out to then losing appetite for other things, and if they lose their appetite again, they will either do more harm to the body by not eating the food and getting pill and pill, or they could gain more appetite and just keep eating and piling on adipose tissue. At some point, it will have some type of negative impact on their cardiovascular system. So either way, coping skills, if it's not done right, it can have a negative impact. It can have impact on the environment or it can have impact on the person. So that person now going through those circumstances can either change their environment that they're in or they can have their environment change who they are. And it is different. It has different reaction to it. It have different result. But she still outlined it into her own way of doing things. Now, you have stressors. There will always be stressors in life. In some cases, for some people, it will be physiological or psychological. Again, physiological part is something that physically happens to your body. Psychological part is you playing tricks on yourself with your mind, asking yourself these questions that you tend to wander around finding the answers for. The patient feels vulnerable and threatened, right, in the environment because they think that, hey, this happened to me. What will happen next? What will be next? What will do this? What will happen this? The patient can also manifest stress in several different manners. They can lose appetite and weight, or they can gain appetite and gain weight, or they can change their body function, other things like that. Same thing. So again, that individual will either change their environment that they are in now, or their environment will have some type of impact on them and change them. Either way, the impact will be negatively impactful. It's not going to be something good for them. But we have to understand some things. We have to be aware of these factors. We have to be aware of the type of things that are going on around them, the nature of the things that are going on, the severity of the illness that they have, the trauma that they have experienced or the disease. We have to understand their previous experiences, because some patient now has previous experience with some trauma or with some events. If these same things tends to repeat itself, they will have a negative influence or negative impact on them, or it will have those impact on them. Now, we talk about the patient age, right? The age of the patient tends to be a little bit different, because the older you are, you can handle stress a little bit differently. And the younger you are, your stress level can be way, way much different. You look at pediatric patients. For them, they feel much more threatened, especially when they are taken from their parents to be transported to the operating room. That's a concern for them because, again, of the age. You look at adolescents, individuals, they are much more concerned. Their primary focus is about their body and their privacy. And then you have our older folks now that are normally worried about multiple concerns, such as death, infirmity, their family, paying the bills, and of course their job security. Because now again, everything is different. Surgery gonna happen, it will happen, and now everyone thinks differently on those different impact, and that's how age played a significant factor in it. Older folks focus on how they will take care of the household when they are out of commission for working for a while, how those bills will be paid, how the kids going to go to school, or how the school fees will be paid, other things like those are things that they focus on. Adolescents, like, hey, you know what, I just need my privacy. As long as, hey, I don't have to expose myself, or you ain't got to violate my privacy, I'm fine. Toddlers say, hey, don't take me from my mother. As long as I'm with my mother, I'm okay. So they have different ways of doing things. And then you have the environmental differences that kicks in. The hospital and the surgical environment is normally definitely not the same as home. And the patient has to quickly adapt to a different schedule, right? Because now, if they're at home, they can do whatever they want. But if they're in a hospital setting, visitation hours is normally straight. The time that they will eat the breakfast is different. The time that they have to go to sleep is different. The time to watch TV or all those things are normally different. And they will have to be constantly waking up to take some type of vital signs and other things like that during the middle of the night. And look at the family role, right? If we consider the family role in this, everything can impact everybody else. Now, an individual who is the primary money maker, right? Almost the same as the age, like those older people. If they are solely and family responsible for 100% or 98% of the income, they're not happy to have a high dependency role. They rely on the healthcare provider, post-operative, he or she to have to rely on other family members, because now if recovery time will take longer time, they can't do anything until they recover before they can go back to work. So now all those concerns and burden falls right back on them. The same thing when it comes down to family road, you have economic factors again. The bills paying, everything else falls on the patient age. If they are older person that happens to have the playing the head of family role, fully responsible for everything, they have that burden on their economic factors. And then you have the religious belief, which of course can affect their attitude and their views of the illness. Now, life and death, and how, of course, the illness or trauma should be approached. Now, religious belief tends to have many different ones, right? When it comes to the treatment option, whether it will be Jehovah Witness or Muslim or other things like that, they have different take on what can and cannot be done, especially for Jehovah Witness. They don't accept blood or blood product given to them. So now, if this procedure will require them to lose more blood and they have to get some type of blood product, you have to look at either giving them a blood extender, but again, how effective would that be as compared to getting a whole blood? Another discussion that they will have to have. So some of these things happen for a lot of different reasons, but they do happen. And then as we continue on, you get to understand some of these common coping mechanisms. But for these to happen, first you'll see that there will be a denial. The patient does not want to accept what's about to happen. They're in denial, it's not going to happen, denying themselves. And we'll kind of go into it. And then you have the rationalization area, where the patient tends to kind of make sense of some of these things, right? Um, One of the good example that a textbook gave, and I've read a lot of it, talks about a diabetic patient who facing amputation. Now, the thing is, they knew about this thing when they realized that they had diabetes, but for some reason, diabetes run through the family, and they ignored that fact. And now it become a reality now because they're about to lose a limb. So they try to rationalize it. What if I knew this ahead of time and took precaution, would this happen? And then you have the regression part. Patient regress to an early stage of life, such okay, so now you get to understand that, hey, they get to say, well, they told me this thing ran in my family, but here's the thing: when I was young, I didn't pay no attention to it. I kept eating all these things, and now it's catching up with me. And then you have the repression part. The patient tends to the patient represses thoughts and feelings about illness or disease and does not want to hold any discussions concerning what is happening. They kind of like in that mode that says, hey, you know what, I don't want to talk about this. No, don't even bring it up. I'm done with it. I don't want to talk about it. So you have those common coping mechanisms that will happen with them. But that's not all to it, because with the coping mechanism going on, you have to look at the other things that will be happening now, where it is accepted, where you get to think about death and dying, because as we go through these developmental stages in life, eventually we'll all seek the same fate. We'll all die one day. So now when that process is coming up, we get to understand what this is when it comes down to death and dying, right? Now the thing about death and dying is this: it can occur in one of three ways, right? The first one is it can either be a cardiac death, where of course we have some type of irreversible loss of heart function. Being irreversible means that the patient passed out or they lost consciousness, and we try to revive them through CPR and nothing worked. So that's irreversible. They died due to heart condition or heart issue. And then you have the higher brain death portion. Higher brain death is just one of three different types of die, or one of three different types of death that we have to understand. That the upper part of the brain, the cerebellum, and all the entire frontal lobe and all those things, they are dead. They ain't gonna regenerate themselves. So the lower part of the brainstem, the medulla oblongata, and those things, they are still functional. However, the only function that they do have is to help maintain the respiration, the blood pressure, and of course heartbeat without assistance of a respirator. So they kind of sort of stay working in there. Right? This timeline is one of the most critical time to see if the patient parents or patient family member might be considering, the Teach Your Life program, donating their loved one body and organ to another person. You have the whole brain death. Whole brain death talks about the entire brain. The entire brain is dead. This right here now, the whole brain death, is the law, or it is the standard that normally defines death. This is how the law defines someone to be dead if the entire brain is actually dead. This one normally includes a flat EEG lines, unresponsiveness, lack of prepuce reflexes, and of course, low body temperature. In this case, spiritual or religious practices and rituals play an important role in the end of life based on the religion. It is important that a healthcare provider be sensitive to some of these things, because then there are some cultural practices that normally honor the patient in death. Now you have the Roman Catholic have a ritual known as anointing of the sick, right? They may perform, it may be performed on a seriously ill person. They sometimes give a last ritual that may be given to a Catholic or Protestant patient before death. You have the Muslim tradition too that might come into request that immediately after death, the patient's body be turned east to face Mecca. Not the burial yet. The burial will occur, but the body itself should be turned east to face Mecca, which is considered their holy city. And then to go on, you have the Jewish person that will come when a patient is dying, right? They should not be left alone. That patient that died should not be left alone. Someone have to be with that patient at all times. The nurse cannot touch the body until the rabbi offers some type of final rituals after death. A son or relative will close the eyes and the mouth of the deceased and wash the dress and body. And the Buddhists, of course, believe in some type of reincarnation, and that the last thought of that person before death determine the rebirth condition. You got the Hindus now feels that hey, cremation is the best way for the soul to begin its journey, right? So all these things normally happen, and we have to respect some of these when whole brain death actually occurs based on the patient religious belief, right? Now we have another one that goes into this now. People cope with grief in a lot of different ways. There are normally 5 different stages of grieving. Any of these stages can happen at any point. It does not need to happen in one specific order. But you have denial, right? Now, these stages of grief was normally out by Elizabeth Kubler-Ross. Brought this out. It happens to everybody. 5 different stages. Uh, they don't go in order. They can happen at any point in time, right? One, we have to be in denial that this is in the initial stage now. Patient may be saying, "Oh, you know what? It can be happening to me, man." They deny everything, usually a temporary defense. Like, nah, it ain't happening. The next thing will be angry, right? As soon as they get that denial over with, they be angry. Again, it does not happen in this sequential order. It can be differently. This guys and they say, "Why me? I did everything right, but why me?" They start their bargaining process. Well, if I do this, maybe this will happen. If I do this, well, let's do some kind of bargaining here. And then go into a deep depression now. Patient could lose some type of sensitivity, don't want to do things, don't want to be social to anybody else. And then finally they get to go through that acceptance process, accept what's going to eventually happen. They have no choice, right? Now, any unexpected death that is tragic will occur. But here's the thing: as they're going through these stages of grief, anyone happens at any time, eventually they will have that final acceptance and they just let nature take its course. But before nature takes its course, we have to look at other things, the general causes of death. Now we know there are 3 forms of death: cardiac, higher brain death, and whole brain death. We understand the stages of grieving. Now we got to understand the causes of death. Now, death happens in 4 different ways. 4 different causes can cause that to happen. You have the accidental part. Again, an accident is something that just happened. It happened suddenly. It happens. It tends to happen with some type of accident, whether it was due to nature or not. You have it could be some type of hurricane, flood, or something, earthquake, right? Those are accidental ones. You have terminal one. Terminal and prolonged seem to be the same, a little bit different. Terminal focus on a patient suffering from some type of disease that has been progressing and that have been progressive and is actually incurable, right? It takes a long time. Look at CJD, can be on board for a long time. It will be progressing. We don't know how to treat it yet, but hey, we can start treating the symptoms. Every time you treat the symptoms, something else comes, which continue to keep happening. But at some point, it will turn into chronic. And chronic death normally lasts for about 4 to 6 weeks because this is something that has been going on for a short period of time. It is long lasting, more than 4 to 6 weeks. However, it may cause life. It may be lifelong. That's why I was saying terminal and prolonged almost the same in the sense that terminal could become prolonged because if so, let's take hepatitis B for an example. Hepatitis B by itself it could be okay. There is no treatment for it. However, as it stay on that patient for a long period of time, patients start developing hepatitis D, going into a chronic fashion. Once that hepatitis D come on board, now it becomes chronic. Anything can happen at any point. So that terminally ill patient now can transition from terminally ill to chronically ill. And then you have sudden death. Anything that just happened or any type of warning. This one, yeah. Well, I've seen a lot of different ones happening in Hollywood recently. but it just happened. Uh, when we start looking at some of these things, we look at other options on what can be done, because each of us happen to have some type of different values and morals guided by our culture, religious, and family values. When we're faced with some of these similar conditions, these values become prevalent in us, right? But what will happen now is we have some type of approaches that we do to it. We have a therapeutic procedure that are normally used to manage some of these diseases. These procedures normally fall into several categories that could either be elective and non-elective type of surgery. The elective surgery part will include placement. Let's just say if something is elective, we're trying to do something to prevent another thing from happening, right? So someone tends to be on track to have a heart attack. They have not had it yet, but we realize that maybe there's some type of blood clot going on somewhere in the artery. We can say, well, let's put a stent in. That's elective. There could be another one that could be a non-elective procedure that we have that we have no other choice but to take action on it. Because if we don't take action, that means something else going to happen. You have another one that will be considered as a life support. The life support session in here is said just a set of therapies that preserve a patient's life when the body system are not functioning sufficiently to sustain that life. That life support system can be used in a surgical setting, put the patient on the anesthesia machine, have them hooked up on it to do the breathing for them. In some cases, the thing's not going right. They might induce, put the patient in an induced coma to help them build up their system before they can have them breathing on their own. So you have some of those things happening. Now, as that's going on, there could be another things that could happen that could change some things around. If we have the life support going on, we have some type of therapeutic procedure going on to help that patient or put a patient on life support for whatever reason, and some of those things fail to happen. We'll also look at euthanasia. Euthanasia can come in a lot of different ways, right? Some states now support it. It could either be a passive euthanasia or it could be an active one. Now, the distinction between these two types of euthanasia is that a passive euthanasia normally focus on the physician, is where they focus on the physician really. The physician, what the physician is doing is they are doing nothing to preserve that life. They just let it take a course. Like we ain't gonna do nothing because that's what the patient wants. The physician does nothing. The active one comes in. This is where something have to happen to either speed up or slow down the process. Meaning, in this case, will be something will happen to speed up the process, and this can be done in two ways. It can either be done voluntarily or involuntarily. If it is voluntarily, that means that the patient is playing a significant part in speeding up the process for them to die. Whether it's to give them medication to the doc or the surgeon or whoever around the nurse to give them medication for them to die, or it could be another form, it could be involuntarily. Involuntarily is the patient, yes, they understand that this is going to happen, but they play no part in it, and someone played a part in it to make that process to go faster. In most cases, that could be on investigation. So those are what we have for euthanasia. You have active and passive, and then on an active, you have voluntary and involuntary. And then you have the other section we'll talk about is the AHA patient care partnership, where we start talking about advanced directive, do not resuscitate, and all those other things. Because we have to respect these things as it comes out. If the patient has a do not resuscitate in the operating room setting, we will resuscitate the patient. Other than that, we have to follow the patient wishes and go on from there. But in most cases, do not resuscitate patient. If that patient is laying on the bed, every effort will be made to save the patient life until otherwise. But if the patient is somewhere else, then of course we can let it take its course. The patient can do what they want to do. And then you have donation after life. Well, we talk about do not resuscitate and all the fun stuff. You have donation afterlife. But before we go to that, let me take a look at this do not resuscitate because I want to make sure we understand what this is. You have advanced directive. We talk about it just briefly. That talks about giving general terms that refers to one of two legal documents used, whether it will be a living will or power of attorney. Power of attorney normally has someone legally responsible or has been appointed as a proxy, right, to make medical decisions on behalf of the patient. Now, another thing is if you have this do not resuscitate initiated, do not resuscitate or do not intubate, right? If this order is there and it's in writing, which is in writing by the physician, states that a resuscitation should not be attempted if the patient suffers a cardiac or respiratory arrest. Now, this order must be initiated by the patient. It is recognized in a medical setting, but the patient should re-emphasize if DNR and DNI is to be honored during a surgical procedure. Many hospitals resent the DNR and DNI during surgery. So this should be discussed with the surgeon, the anesthesia provider, and other surgical team members. Death of a patient in the operating room can be sudden, such as cardiac arrest during a scheduled procedure or maybe anticipated by a patient family and the surgical team. For abdominal aorta aneurysm, for AAA that normally occur, that has a good chance of rupture or rupturing, the patient death occur in the operating room, in the hospital, in the operating room. The hospital policy and procedure must be followed by the surgical team and consistently applied. So patient going up, that's why I wanted to make sure I clarify this right here, because do not resuscitate in as much as I'm saying that patient do not die in the operating room. If the patient going for some type of procedure and it happens to have someone that has that power of attorney to make the decision, the patient can make decision for themselves at that point. It have to be discussed with all the surgical team, including the patient. The patient have to state out loud, say, hey, if anything is to go wrong, I don't want you intubating me, I don't want you resuscitating me, and all those other things. If that's discussed, okay, we can kind of sort of take a look. But other than that, it ain't gonna happen in the operating room. It will be a little bit different for that to happen. And then we have this other section here that talks about organ transplantation. When the patient dies, their organs and how the organs are normally donated and all these things. The gift of life is one of the best things that anyone can do for another person, because donation after cardiac death focus on considering a patient as a candidate for DCD only if it is predicted that the heart will cease functioning within 90 minutes of removal from mechanical support. Now remember, higher brain death, a patient is not on any type of tube, right? Respiration and heart rate and all these things is still functional. Whole brain death, if that patient, if they identify what's going on, the patient is placed on a machine to help circulate blood and other things like that to those organs to keep the organ viable. But at that point now, patient family member have to decide what they want to do, because the moment they take that patient off that life support, they have 90 minutes. If that within that 90 minutes time it cease functioning, that's the time they have to make those decisions to reserve those organs. Other things that will happen for patients who were not placed on or they were removed from a life support aspirator or something like that, when they die, we are able to recover their cornea, skin, and bone. If for some reason they were not placed on some type of ventilation and they died, we can be able to make use of the cornea, the skin, and the bone to use for someone else. But for the heart, the lungs, and other tissue, the patient needs to have some type of oxygen and heart rate, some type of blood going in and out to help that process. I know talking about death and dying, talking about other people donating their body is weird, but we have to discuss it. And now Master came up with his hierarchy of need to prioritize some of those things that were discussed previously. And he came up with this a model of human development, developmental stage. We all know where we go from childbirth all the way. We start crawling, go on through the developmental process, and all the way to geriatric, and on and on and on. Expressed in terms of a hierarchy. Now, his needs focus on these things. He changed those things that we discussed previously and put it in a hierarchy form. He has physiological safety, love and belonging, self-esteem, and esteem and self-acclimatization. Best way to look at this is this, right? The physiological need, something physical. In order for us to survive this physiological aspect of it, we need to be able to have what? Food, water, and oxygen. If you have food, water, and oxygen, you have met the requirement for that first stage. Now the next thing we have to look at now is go on towards safety. If your environment is safe, if you already have food, water, and oxygen, and your environment is safe, you can go on to the next one. But if you don't have a safe environment, you ain't gonna make it. You will be dead in a couple of hours or a couple of minutes because your environment is not safe. But if the environment is safe, that gave you longevity. You're going through the developmental stages now. And then once you make it through the safety aspect of it, you will get to this other session now we talk about love and belongings, right? In this era now, we try to socialize ourselves with the environment. Um, we tend to be part of a group. We tend to, how you call it, start making friends, start having, thinking about having family and other things like that. That's the stage we start doing some of those things. When we get to prestige and self-esteem or esteem needs, we sit in this era now and say, hey, I have done all of these things. This is what I need now. Maybe I was looking for my family. I need to start creating my family now. I have to start doing this. I need to go achieve my goals. I have to do this. That's where this other session comes in, the esteem era comes in. Once we achieve that era, we achieve the esteem era now, we're going up to the last era now where it's considered to be self-acclimatization. This era now will sit up in this era and then reflect on what we have done. And then start going back and say, well, if I was to go back in this lifetime, I would have changed this, changed that, or changed that. We start using our story as some type of motivation for the newer generation that's coming up. So at least they can go through their own processes differently and don't have to do the same or make the same mistake that we made when we were going through ours. That's how Maslow did his to help this process. So he looked at the the physiological to be the most basic needs for us, right? Which of course will be the oxygen and other things now. Safety needs, I just discussed the self-acclimatizations, the self-fulfillment, what we believe is our one's purpose. And then you have cultural and religious influences. These ones happen in a different way because then we start looking at cultures and religious influences. Now we got to understand that every single religion is having to have their own personal needs. You have Jehovah Witness don't allow organ donation. They allow organ donation, whereas Protestants and Roman Catholic they are normally permitted. Uh, American Indian discourage it. So a lot of different things. Jehovah Witness does not allow blood product to be given to them, right? But here's the sad thing. Here's something interesting. It's not sad but interesting. When it comes down to abortion, right? Roman Catholic does not entertain abortion. They don't allow it. Protestant in some circumstances they will allow it. Jehovah Witness does not allow it. When it comes to the moment, it has to be specific conditions. American Indian does not allow it, and some circumstances will apply for Muslims. So all of these things are different things when it comes down to culture and religious influences. They have different ways of doing things, especially in the operating room. When it comes down to giving blood product to a Jehovah Witness, it becomes a problem. There are other avenues that can be taken. The last step of that would be getting the court system involved to make a decision on giving blood product to a Jehovah Witness if it is needed to save life. And then this was a case study that we can, well, I think we probably already discussed this, but you can read it and see if you can answer some of these questions on your at your earliest. All right. This concludes chapter 3. We were to review patient responses to illness and hospitalization, trying to understand what will happen based on the different age group, what the primary focuses normally are when it comes down to infant or toddler, normally focusing on separation anxiety, looking at adolescent, focusing on their own personal privacy, and adults or geriatric, focusing on bills and other things like that. You have physical, spiritual, and physical, psychological needs of a patient, where on the master hierarchy of needs, he outlined those things in a different way by putting everything in a way that if one is accomplished, you focus on the next. If the next one is accomplished, then you can go to the next stage. But if one stage is not done, the follow-on stages cannot be completed. And then we talk about culture and religious that's influence on the subject of patient, which we try to understand why some of these religions happen to have specific indications on what can be done with a body in the operating room, a body in the morgue. And we do our best to honor those wishes of their religions, and be supportive of what they have to do. All right, this is the conclusion of chapter 3. I look forward to seeing you in chapter 4 again. Same way, just as usual. If for some reason you happen to have any questions, send me an email. We'll meet in class for our next discussion. You can bring that up and we'll be able to address those things. I encourage you to continue to do the chapter exam test, because we have 2 more chapters for you to take your first exam. All right, we'll see you again next time. Thank you.